Hi everyone, thank you for joining and for participating in this webinar dedicated to the guided lower class therapy. We apologize for the few minutes regarding this technical issue, and we found a way to provide you with this great GDT presentation. First of all, quick introduction. So my name is Marie-Christine Colette. I'm an education specialist promoting the Swiss Lower Class Academy and guided lower class therapy training programs worldwide. So we are with you today to offer you a GDT presentation, and welcoming today our expert, German expert, Dr. Peter Stiller. Peter, thank you for being with us today. Just a few technical points before starting this webinar. As you can see on your screen, you have a chat and a Q&A icon, so please feel free to use them and ask your questions. We'll be able to answer them during the course of this webinar or at the end of the webinar if it's easier for us in terms of techniques. Well, that was for the introduction. Thank you again. And Peter, the floor is yours.
Thank you very much, Marie-Christine. Welcome to all participants. Good afternoon. I hope you can understand myself better than Marie-Christine. I have the same problem to hear her. Can you please send me a short message if you understand me better than Marie-Christine? Is it possible in the chat, for example?
Yes.
Okay, yeah, perfect. We have some, perfect, thank you very much. We have some, that's the proof that nobody's sleeping already. We have some technical problems. One is that I cannot bring in my own files with my notifications, so Marie-Christine has to go further with the files when I tell her. That's not the technical best one that we had before, but we try to do it as good as we can. The next file, please, and then the next file, please. Did you change? Okay. This is my introduction. I think Marie-Christine did this in a very good way, so I don't have to do it again.
Sorry, I have some trouble. I don't know what happened.
Okay. First of all, I want to show you that the network that we have in our background for the GDT or the whole shockwave therapy thing is very, very big. I have a few of them that we work together in network here on this file. It's, you see there are about 12 doctors, team doctors from professional sport teams in Germany, all from the first league. It's basketball, it's football, it's everything that you can imagine. We have 5 physiotherapists from the first league football. So you see people with high quality and high level of experience are all in there. So what you hear today is really something that is proven over years. The next file, please. Now, when we are talking about the practical thing and the guys working with the dollar class every day and the GDT every day, we have to talk about Professor Christoph Schmitz from Munich. He's I would say, one of the 3 most famous science professors in the world, thinking about or working with the shockwave and the laser, and stem cells is one of his next levels that he reached. He's head of the Department of Neuroanatomy in Munich and a member of the Clinical Sciences and Research Committee. You know, most of you will know him. I introduce him as, first of all, as my mentor. So everything that you hear from me is exactly what he reached out the last years with his science, and all the results that I present you today are from him and his great work over the years. Okay, next one, please. What is new to the old webinars that or older webinars that we did is that we now have the GDT, means the guided dollar class therapy. It's a bit more than only shockwave, as you see. I know that most of you know that a good anamnesis and rehabilitation and a follow-up evaluation is pretty normal for you all, but the 3 steps in between is that what we want to talk about today. First of all, the very new device, the high power laser, the dollar class high power laser, which gives us much more possibilities working with shockwave. And then the new dollar class radial shockwave, which is portable now. And you all know the focus shockwave, and how you can use them together we will discuss today. Next file, please. Here is, for all of you, I think in very short, what we can do with the laser and how we can work with the laser and with the radial and focus shockwave. This is a comparison of all that you will hear in the next step. So I will not talk about this one in detail now, because we go through the steps during the webinar. The next one, please. This is how we work with it and what we want to reach. Here you see the 2 devices. The next, please, left is the laser and right is the new shockwave device. And as you can see, we used it month and months before now to be able to show you how it works. And this is one of our works with a patient with polyarticular arthritis in the hands. We had this article in the sports medicine, what is it called in English? Sports medicine. Marie-Christine, help me.
Yeah,
sports medicine. How do you call it? Sportärzte-Zeitung in Germany, sports medicine newspaper, they call it. Okay. It's the international one in English. And we had this about, I think, 6 or 8 months ago. The next one that you see is from Alexander Ablas. He is a very well-known and famous physiotherapist in Germany. Next file, please. There we used it with an rupture or tear of the ATLFL. He's very well known for that because he's working with professional football players every day, and you can see the results were great. Next one. Okay, now let's talk about the theory behind it. I start with the theory of the modern laser therapy because it's much shorter than the theory of the shockwave. Very important is that we have a therapeutic window that we work with the laser. It is between 650 and 1,350 nanometers. In this wavelengths, it's called therapeutic window because it gets very deep if the absorption by water, blood, and melanin is not so high, but the best wavelengths that you can have is 905, as you see here at the high power laser of EMS. This is the point you see on the right side in the diagram. This is the point where it reaches the best depth without heating up and with the most energy in deeper parts of the tissue. Next one, please. As a high power laser heats up the tissue every time you use it, not with 905, not as much as the others, but the high power means that it heats up very, I would say, in a short time, not as the others, but as not too fast to hold on it. And so we have to pulse the laser, and EMS did it with, as you see it here, with peaks of 300 watts. This is the high power that I talked about. And then it switches off and on all the time. We see in the next then. But if you see the competitors on the market, they have a high power of 20 watts. So we are pleased that it is pulsed because we don't want to burn you. Next one. This is how the 5 points that we have to have in mind when we use the laser work together. We have a peak power, as I said, 300 watts. We have the average power, which shows us how much energy comes overall during your treatment into the tissue. It's very important that this is not too high. And now if you change the frequency of switching on and off, this is what we call pulse, because the frequency tells us how fast we switch from on to off. The pulse duration is how long is it on and how long is it off. And the modulation is the percentage of all when it is on and off. And this is all according to the overall amount of energy that we bring in. And the pulse duration is very important. If you have it very long, you get more power at its peak, but you have to be careful with getting warm, and that's why it is very important that these programs are already programmed in the device, so you don't have to do anything. The devices are programmed, and you can start immediately without burning the patient. Next one. Now we start. That's it. Well, we start with shockwave. What we want to talk about today, the first is evidence-based medicine. I don't want to bore you with studies, but we have to talk about a few of them. That's very important. Then how works the technology behind our devices, the molecular and cellular mechanisms that are working in the tissue, the indications and the contraindications, and I have one special one for the first time diagnosed tendinopathies, how we treat them and why we treat them. So good. The next one, please. What do we want to achieve and give you on your hand that you know what we do is really good medicine and very good for our patients? We want you to have less medication necessary, no injections. I really say no injections because over the years, I would say 10 years ago when I started, or 12 years ago when I started as team doctor of FC Augsburg here in the German Bundesliga, I didn't have the shockwave device, and so we had a lot of injections that I don't do anymore today, not at all, and especially no cortisone. Fewer operations or no operations, maybe. We are working non-invasive. That's very, very important because it's less risky. And we have a high effectiveness of overall over the world, and all indications that we have about 80 and more than 80%. So the happy patient is a successful practice. That's right, yes. The next one, please. The science behind it. When you talk about science and Professor Schmitz, we talk about the PEDRO database, a physiotherapy evidence database. There are over 48,000 randomized controlled trials in it, systemic reviews and so on. And very important is that this one is meant as physiotherapy, as all kind of non-invasive or conservative orthopedics. That's a bit different in Germany, for example. We have physiotherapy, conservative orthopedics, and surgical orthopedics. In other countries like Australia, Norway, Netherlands, I don't know how it is in all the other countries, but these countries are known for very broad education of the physiotherapists. It's a study there for over more than 4 years. And sometimes even with a bachelor. And so you can be sure that there's a lot of information and a lot of things that you really can use for your daily practice, because it is it's a high level of studies that have to or can go into PEDRO. The next one, please. And it's situated at the University of Sydney. Next one, please. This is what I meant. The reliability and validity of the PEDRO database was also proven in some studies only about the validity and reliability and how it is based on the Delphi list. And they all prove that it's one of the best databases you can have in the world. Next one, please. Sorry. I always try to push. This is to show you when shockwave studies started. In the year 1996, we had the first in Pedro. And then in 2003, we had the blue ones. It means the focused one started 1996, because focused we have much longer than we have the radial one. And radial studies started 2003, 2005. And as you can see at the end, it's going on like you see it here. We have much more radial shockwave studies now than we had before. You can say focused. We know everything about focused, but we don't know everything about the possible indications, and you will see that afterwards, the possible indications of radial shockwave. That's why we get more radial studies now. Next one, please. As I said, I don't want to bore you, but in this case, I have to show you some studies, not talking about one or two, but talking about all the studies, and to have you that you have in mind that the most of the studies were made with the Swiss dollar class. Here it's in red. You can see 75% of all the studies that are in Pedro are made with the Swiss dollar class. To show you one or two special ones, I would like to have you see the subacromial pain syndrome and the studies by Mrs. Engebretsen. This is very funny because they had a negative outcome. It was clear at the beginning that they get a negative outcome because the subacromial pain syndrome is meant under the subacromial pain syndrome in Norway, they also include the complete rotator cuff rupture, which is very funny because nobody can heal a complete rotator cuff rupture by shockwave. So it was clear that they get a negative outcome, but it's, yeah, they do it in Norway. And if you see the plantar fasciopathy, there is a work of Mr. Rompe and his team with a negative outcome. Just keep that in mind for the end. I will show you at the end why this is the case. Next one, please. Important conclusions. I shortened it off to 3 points, very important. If you have an overview, as Professor Smith had over all the studies, there was the first point and most important point. There's no general advantage for the focused shockwave over the radial shockwave, and everybody the years before told us that high energy is focused, or focused is high energy, and it's the better shockwave, and low energy is radial, or radial is the low energy, and that's absolutely nonsense. As is said here, it's often made this comparison in the literature, but that's absolutely wrong. Please forget what you heard about high and low energy. I'll show you in a few files why this is wrong. And 75% of the RCTs are made with the dollar class, as I said before. The next one, please. Technology. What kind of shock waves do we have? We have the focused one, which is nearly the same from the technical point of view, nearly the same than the one we use in urology for cracking kidney stones. It is focused on one single point, and that's why we can crack the kidney stones. Or, for example, if you have a calcification in your shoulder, that's nearly the same from the technical point. And if you have the other side, the radial shockwave device, that works completely different, but with the same results, as you can see today in the next files. And since we had this radial shockwave device, we could work much better on the musculoskeletal system than before. Next one. If you see not RESWT but RSWT somewhere written, this is only that this is a registered trademark of EMS. It's the same. It's also radial shockwave, but it's radial shockwave with the Swiss dollar class. So it's the only one you should use. Next one, please. Here are some examples how shock waves, these acoustic impulses, pulses, can be seen all over the world. For example, if a warship fires its guns, or if a jet strikes the sound barrier, then you have energy like a shock wave, and the same energy that you can reach by the shockwave device we have. But, and that's the next one that comes up. Next file, please. The physical definition of a shock wave, a single acoustic pulse with more than 100 megapascal and very, very short rising time from less than 10 nanoseconds, between 10% and 90% of the peak pressure, and a negative pressure wave afterwards with about -10 and more than -10 megapascal, and a very short lifetime of the shock wave. This is only the physical definition. Next, please. This is exactly from the what you can see here from the times and from the pressure. This is the physical definition, 100 megapascal, 5 to 10 nanoseconds. If you see the next file, then you can see that for the shock waves, I mean, that's it for the therapeutic shock waves or pressure waves that we need. It's completely different. We need about 10 to 100 megapascal. The rising time is about up to 1 microsecond. That's much longer. That's a big difference. You will see the next files. Professor Schmitz, Mr. Rompe, and Professor Furia, these are, I think, the three most important scientists in the world for shockwave. They did a big study to prove that it's not necessary to have real shockwaves from the physical definition point. But as you can see here, it doesn't depend on this, but it also works. Next one. That was very important because you can only reach, as I show you now, reach with one device and with the highest setting these real shock waves. All the devices that have lower pressure, as you see here, for example, the dual lid of Storz, they have a peak pressure between 2 and 45 megapascal, much less than we had with the piezo-clast, and also the rising time is between 8 and 500 nanoseconds. It's much more than we saw before. What is important is they cannot form. It doesn't matter what setting they have. They cannot form real shock waves, but they said in this study, a true shock wave could be obtained in water if the initial pressure output of the device were doubled. That's important. And that's important because, next file. If you compare the highest peak of pressure of the dual lid with 42.7 megapascal and 82.2 of the piezo-clast, it's exactly doubled. And can you go on, please, with the... Thank you. Once more. And the energy is also doubled. It's from 0.23 to 0.4. That means doubled pressure and doubled energy. Next one, please. Yeah, there's it. There it is. And the next one. And now I want to show you how, from the technical point of view, how the radial and the focused shockwave work. The radial is a ballistic generation, means that compressed air comes up into and accelerates in this, I call it the pistol. It's called the handpiece, of course. I call it the pistol. Accelerates a projectile which strikes the applicator with up to 90 kilometers per hour, and then from the applicator, the radial shock waves are released, as you can see here in this picture. The second hand, if you go once further, the new handpiece is coming up, I think. I hope it works. Yeah, that's the new handpiece, and exactly the same. Now we have the video, how it works. Yeah, perfect. You can see the first front of the shock waves at the beginning, and then there's a second one coming up, smaller circles, and between the smaller circles, this is not pepper, as you can see here, the black dots. This is these are cavitation bubbles, and very important for the results that we get by shockwave. Next one. Okay, there you can see it on the picture. We have the wavefront for the primary shock waves, then the secondary shock waves in this little circles, and the cavitation bubble here. Wonderful exemplar. Next one. What is very important is that the difference between the EMS dollar class, the old one and the new one, to the competitors is extremely. As you can see here, the dollar class goes up to 4 bar. That's the highest pressure that we can reach. But it doesn't matter how the pressure is, it's important how many energy comes out. The energy flux density is important. And if you look here, we have 0.18 at the beginning, and we have it up to 15 and nearly up to the frequency of 20 and 25 hertz. All the competitors lose at the beginning, they start to lose energy. And if you go up to a frequency of more than 15 hertz, it's like you work with 0.3 bar or less than 1 bar with the radial shockwave device of EMS, the dollar class. The next one. And this is very important for all your, for everything you are doing in the future. With any other device, you always know that nothing comes out. That's the problem. So the technical point of the focused shockwave, here we see the piezo class from EMS. It's the piezoelectric generation. The high voltage is applied to piezo crystals, piezo ceramic crystals. We have 1,000 in a bowl here, and they generate 1,000 little pressure waves with a lot of energy, and then these 1,000 waves come together and converge into a shock wave that focuses on one point because of the ellipsoid alignment. And as you can see on the right side and the next file, we get a focus in the middle that is okay, sorry. This is how we can generate focused shock waves in other ways. It's the electrohydraulic and the electromagnetic way. Electrohydraulic means from the point where the probe has its end, there comes a very high energy heat that forms under the water, forms gas bubbles that implode and have a lot of energy from the elliptic form. They smash to the one point in the focus, and the electromagnetic is we have a line up magnetic, as you can see in number 1. Number 3 is a membrane, and then we also have high voltage on the magnets, and then they move the membrane, and the energy that is coming up is focused by an acoustic lens. And we have the same focus as with our piezoelectric. It doesn't matter what kind of generation we have. Next one. So now I can show you what happens with the focused shock waves. They start and then they come together in the middle. The video is a little bit slower than normal, but I think everybody can see that we have also the first front, secondary shock waves, and in the middle then very concentrated. That's the big difference, very concentrated cavitation bubbles. Next one. Here you can see the shock wave focus in the middle, the cavitation bubbles, and the secondary shock waves. The secondary shock waves release when they crack the cavitation bubbles and they implode, release a real jet stream. We will have this word afterwards in another file, and this is much more energy than only the first front of the shock wave. Next one. In this, you can see the focus of the highest setting that we have for the piezo class. It's intensity 20. It's when the device really generates real shock waves, and then you have a focus of a length of 5 and a wide width of 2 centimeters. That's the biggest one. If you put down the setting, the focus gets smaller and smaller. Next one. Here's compared the radial one on the left side to the focused one on the right side. Now we have settings with about nearly half of the pressure that they can bring. If you have 2 bar, for example, here on the left side for the radial, you have only 5 megapascal. This is a long way to the 100 megapascal that we had at the beginning, but it works, and that's the most important thing. You don't have to always use the highest settings, and you see that the cavitation, for the cavitation, it is not, absolutely unnecessary to go higher, because we have minus 10 megapascal also with 2 bar, and it also only depends on what your patient holds on to it. On the right side, you see the piezoclast. Here we have 10, an intensity of 10. It's the middle of the setting, and we have 30 megapascal, and not the highest part with 110 or 115 that we reach with the intensity 20. Next one. This is, as I said at the beginning, you cannot say that high energy is always for focused and low energy is always for radio. Can you go one further, that I have the arrows in there? Because what I want to show you is that, that's perfect, that it depends on the handpiece. The radial handpiece that we normally use, the Evo Blue handpiece, goes up to, I think, 0.3 millijoule. I have to have a look afterwards. 0.3, I think, millijoule. With the Power Plus handpiece, we have about 0.55 millijoule with this radial device. Oh, sorry, the Evo Blue is 0.18, and you can get it a little bit higher. But here with the Power Plus handpiece, you have 0.55 millijoule. This is much higher than one that you see down there, 0.5 from the piezoclast. So you cannot say piezoclast is focused, so it is higher in energy and higher in pressure. That's not right, that's wrong, and here I can prove it. Okay, next one. Here is a study that only says that the cavitation is very, very important and has a significant tissue effect when you work with shock waves. And how it is created, I will show you with the next one. Here you can see that that it starts, cavitation starts from the beginning on, but the cavitation bubbles really get bigger and wider when you go into the negative pressure phase of the whole wave. And then, as I said before, it comes to the jet stream because these big bubbles implode, and there's a lot of energy that gets free through this jet stream. The next one. And this is, for me, this is the most important file that you can show for the cavitation and how the devices work and how good this device that you see today works. If you compare EMS, and we have to look at EMS-E and EMS-P, means Evo Blue and the Power Plus handpiece, and please compare these two to BTL or Storz. Don't compare it to Simmer, because as you see there, nothing comes out there. This cannot be called shockwave. But if you compare 1 hertz, where BTL and Storz work, I think you can say properly, with 4 and 5 bar, and then we go to 15 hertz, you see that there's no way to really compare EMS to BTL and Storz, because the 4 bar 15 hertz cavitation that occurs is much more than you can reach with the other ones with 5 bar. And I'll show you this in 2 videos with the next file. Next one. This is just photos. Now, here, this is when the computer counts the bubbles, then you see the peaks over here, or the diagrams that we see. Now, if you compare, it is even more clear than it was before. See the EMSE and the ENSP with 4 bar 15 hertz and compare it to the 5 bar of BTL and STORZ 15 hertz. The difference is huge. And now the videos come, I'm sure. Yeah, this is a comparison of STORZ and BTL with 5 bar on the STORZ, 6 bar on the BTL, with 4 bar and 11 hertz, so that that they can be compared a little bit, because 11 hertz means that both work properly. Of course, dollar class works always properly up to 20 or 25 hertz, but the other ones lose a lot of energy. So we chose, or on the videos they chose 11 hertz. And now I hope you can see, because the video is not very fluent today. Can you see? Yeah, you can see the bubbles. And I know there are a lot of people saying, oh, you use sparkling water on the left side and still water on the right side. No, it's both still water. And you can see the cavitation coming up from the handpiece of the dollar class left side. Now start the second one, please, Marie-Christine. The dollar class handpiece on the right side, and the other one on the left side. And those videos speak for themselves. You see how much cavitation comes out from the dollar class handpiece and from the other one. Okay, next one. Now we go into the molecular and cellular mechanisms of action. Yeah, that's okay. Just go further. Yeah, this is a file that concludes everything that you will hear on the next files. That's just for you, and I think this is very good to show to the patients, for example, or if you want to train someone, you can show this, because everything is not in detail, but very good to show to others and to teach them. Next one. Now we start with what is the effect of a shockwave that we want to reach, or that comes up. It's the pain relief or elimination, if it works the best way. The second one is the increase of blood circulation. Everybody knows that, I think. For me, the most important are 3 and 4, the inhibition of inflammation and the activation of reparative processes in the tissue, because this is what I call regenerative medicine, and what I want to do for my patient. And the muscle relaxing effect is a very good side effect. Next one. To understand how it works, I just want to explain, but everybody knows that, I think, how the model for tendinopathies works. I mean, how they occur. You have a load that is too much, an excessive load that is too much acute or chronic, and then we get a reactive tendinopathy that the most of the guys don't really recognize, because they don't give a shit on pain and work on, and then it goes with a tendon disrepair. And can you get the arrows in, Christine? And then we have this kind of disrepair and not starting the repair mechanisms that we have. And so in this stage, we can work perfect on it and get a perfect result, because it comes back to a completely healthy tendon. But if you go further and we get the degenerative tendinopathy, the reversibility is unlikely. And with shockwaves, we can get it better, but a real healing is very difficult at this stage. Next one. Now we have to differentiate between acute tendinitis and the chronic tendinopathy that we saw the last file. Acute tendinitis is no indication for shockwave because it starts from the beginning. It gets or the pain is so fastly rising that the patients go to the doctor after a few hours. In this situation, you cannot treat with shockwave normally because they cannot hold on to the pain. It is too painful for them, and so this is the moment for ice and, for example, the laser, because the laser is very good for I would say for getting the pain nearly away from the beginning on. That's why we use the laser with ice at the beginning, and after that, if you come to the next phase when the pain is going under this line up there where it's called decision to see a doctor. If it comes down there, then you can work with shockwave. That's what we do with acute injuries for professional sportsmen. But what we normally treat is the chronic tendinopathy, for example, when the pain comes up. It's not so much that you go to the doctor, and by the time it goes a little bit more away and then it comes back and reaches the top, which is not that the people are not able to stand, and then they go to the doctor, and then you can treat them with shockwave. Next one. Why is that so? If you see how the tissue reacts after an injury, we can explain how shockwave works. The substance P is released as a neurotransmitter that is released from the C fibers of the C nerve fibers when you have an injury in the tissue, and then substance P leads to mast cell stimulation, and histamine goes out of the mast cells, and the substance P also has an influence on the blood vessels so that they open up, and we get a big edema in this tissue, and hyperemia and erythema, which means that we have a real inflammation there. They call it neurogenic inflammation because it comes from the peripheral sensory neurons. And this neurogenic inflammation, I think you all know, if you know Dr. Müller-Wohlfahrt, because this is what he told the world 35 years ago. And that's why he was so successful with his treatments, because he always thought about getting hand on this neurogenic inflammation and get healing, because you get the inflammation away. Next one. Yeah, I can even do the next one. The red hot chili pepper is very important for explaining the mechanism of action of shockwave, because the red hot chili, everybody knows if you bite on a red chili pepper, you have this burning heat on your tongue. It's painful, and if you do it 2 or 3 and then 4 and 5 times, you think about getting numb on the tongue, because the pain is going away, but the feeling also. So this is what capsaicin. This is the ingredient that is contained in the red hot chili pepper. Capsaicin has this effect on substance P, because substance P is activated by capsaicin, and so you get the pain at the beginning. Then afterwards, the dapper is cleared of substance P because of giving capsaicin again and again on the tongue. And then it gets numb because there is no more substance P as a neurotransmitter to start the pain. I call it first it burns, then it goes numb. If you see what shock waves do, it's exactly the same. Shock waves release the substance P in the tissue, and so you feel the pain, and your patient feels the pain. That's why you have to tell them at the beginning that you will reach a pain level that should be okay for the patient, but you have to have a little pain to that you can tell the patient how it works at the moment. And then if you have the pain and you talk to your patient and he tells you, no, it's getting better and better, then the substance P is going away, the depot is cleared, and then the patient says, oh, that's much better than before. And that's how it works. And because you have this depots cleared from substance P, we have no more pain, but we also have no more neurogenic inflammation. That's very, very important. Next one. Because if you have less substance P, as I said, you have less pain, less neurogenic inflammation, but then you can go on MC because the arrows are coming down. Because then, in combination of the decrease of the neurogenic inflammation and the release of growth factors, which is another very important result of the shockwave therapy, go on, and the activation of stem cells, which is all proven in the, perfect, thank you, that's okay, which is all proven in studies that you can see down there. Studies by Wang and Hoffman over the last years from 2006 and 2008 is clearly proven that the release of growth factors comes from shock waves and the activation of stem cells like fibroblasts or osteoblasts. Is also proven in the science, and this together leads to healing, and that's what we call regenerative medicine. That's what we want to reach. Not only that the pain goes away, because this can be with local anesthesia, you also get the pain away, but you don't get any healing at all. The 0.5 on this file means that if you work on the nervous system, as what you can do with neuritis, for example, neuritis, the effect of the shockwave comes especially from the cavitation, and that is very important because for the cavitation is very, very good, as you saw before with the Swiss dollar class, and so you can treat this indications better. Next one. I want to read this loud because I think this is the best summary that you can have for how shockwave works and why it works. The prolonged activation of pain and heat sensing neurons, unmyelinated C fibers by capsaicin or shockwaves, depletes presynaptic substance P, one of the body's neurotransmitters for pain and heat. The result appears to be that capsaicin mimics a burning sensation and pain. The nerves are overwhelmed by the influx and are unable to report pain for an extended time. Period of time. With chronic exposure to capsaicin or, as I said, repetitive shockwave, neurons are depleted of neurotransmitters, and it leads to reduction in sensation of pain and blockade of neurogenic inflammation. If capsaicin is removed or shockwave is removed, you don't treat someone or ours, the neurons recover. And this is very important that they recover because you have to have the possibility to feel if a new pain comes on and, for example, it maybe that their tendon gets a rupture or something in the future, you can feel that because it is not completely numb, but the neurons recover. This is a very important point. You don't use local anesthesia when you work with shockwaves, not at all and never. I say that in that way because now we have some, I would say, very famous people for shockwave therapy over the last years and decades that tell different things, and that's absolutely nonsense. For example, Mr. Gerdesmeyer, who was here part of this study, that proved that you reduce the efficiency of shockwave when you use local anesthesia. He's now working for Storz, and we have videos in the internet that he tells the people always work with 4 or even 5 bar, and if the patient doesn't hold on to that, use local anesthesia, that you can go on. And that's absolutely nonsense, and please don't do that. Next one. How does shockwave therapy work? As this is a little comparison. It increases the release of numerous messenger substances, as for example substance P or CGRP, and it leads to analgesia and increased blood flow. We have additional to the work that it does on the C fibers. The gate control principle means an overstimulation of the A delta nerve fibers that work back on the C fibers, and the result comes from that the A delta fibers work on the C fibers too, and not only for themselves, as I can say. And that's why the gate control principle brings, I would say, a little result on top to that what we heard before. The activation of cellular defense and their own repair mechanisms is the most important one for the patient and his body, because this new sprouting, for example, of local nerve receptors, neovascularizations, angiogenesis, and the stimulation of fibroblasts, osteoblasts, and so on, is very, very important for the healing. And the fourth point, the inhibition of the enzyme COX-2. You all know the COX-2, the antiphlogistic effect of medicine working on COX-2. This is the same, but it is a local effect. Not as you don't have to give a pill. You work local on the cyclooxygenases. And the point 5 is that the vibration of the tissue leads to more muscle relaxation that we have from the anti-inflammatory effect. Yeah. What does shockwave therapy do? Is just the summary of all that we said before. You have the reduction of the chronic pain, the blockade of the neurogenic inflammation, the activation of mesenchymal stem cells as osteoblasts, fibroblasts, the release of growth factors, very, very important, and you improve the blood circulation in the treated tissue. And that together brings you all the effects and results that we see. So now we come to the indications, and we start with the indications of the laser. The laser effect with our 905 nanometer laser goes over tendinopathies, knee osteoarthrosis, and the muscle regeneration. I want to show you these 3 points because there we have a lot of studies that prove that. First of all, tendinopathies. We use the laser together with shockwave because this is a study, for example, for the nociceptors. Here we have the tongue of a cat. They put some heat effect on the tongue of cats. If you see it on the as you see it on the right side, point A is where they set the first pain on the tongue with up to 47, and right side 53 degree, and the nociceptors are going very high, and then they put the laser on it and do exactly the same after 1 minute, 3 minutes, 5 minutes, and 10 minutes. And you can see that the nociceptors are not firing this in the same frequency, in the same strength than before. And this is the effect of the laser, so that the pain goes away after a few minutes. It starts and then it goes on for more than 1 hour. And this is very important for us to use, as I can show you afterwards, with shockwave therapy, because if they have less pain and it's not the same numb feeling from local anesthesia, that's very important. It's completely different. So all the effect that you have with shockwaves, do you also have when you use the shockwave after the laser, but you can put more pressure on it, give more energy in the tissue, and so work much better and have stronger results. The next one. One back, please. Yeah, that's it. The laser reduces prostaglandin E2 concentrations in the tissue, which is it's a very nice side effect that we have and that we can use for the inflammation in the tissue, because prostaglandin E2 is not as important as substance P for all the inflammation, but if you can if you can put the prostaglandin E2 concentration down, you also get anti-inflammatory effect that we can use. And as you can see here, it's significantly reduced in this study after 75, 90, and 105 minutes. So it's really a lasting effect. That's the second indication that we have to show you, because there are a lot of studies. Just show one. There are a lot of studies that show that the patients treated with 904 in this case, or 905 nanometer laser, get much better with the pain in their knee osteoarthritis, and that's what we use, or what we make of use to us or for us when we treat the knee osteoarthritis with shockwave, because we have a summary effect. It comes together and makes it even more likely to get the patient very, very good in short time. Next one. Muscle regeneration. This is not a study for the laser. This is just to show that it is proven by this is Professor Matiasowski. He's the team doctor of Mainz 05, one of the Bundesliga first Bundesliga clubs in Germany, first league. He did it together with Professor Schmitz, as you can see here, and they found out that shockwave is a very good treatment for the injury of muscles, and can the gene expression of human skeletal muscle cells is can be modulated and increased by shockwave. A very interesting study. Very for us, it's very important for the last years, because that's why we treated so many sportsmen and so many muscle injuries over the last years, and with so much success. Next one. And the laser is perfect for us to use in addition to the shockwave, because with the laser you can reduce the inflammatory response and the reactive oxygen species that you have in the muscle when it is hurt. Every injury brings up an inflammatory effect in the muscle, and the reactive oxygen species increasing, and we can stop that with the laser, and also the activation of NF-kappa B, which is very important for keeping the inflammation down, because NF-kappa B is also bringing up the inflammation and building more collagen, which means that the scar tissue is starting very early, and we don't want to have so much scar tissue in our muscle. This very important is the next file for this too. Because here you can see that the collagen remodeling can be a little bit stopped or made slower by the laser, and so we have the possibility, or the muscle has the possibility to build more muscle cells. The fibroblasts can work better without building a scar tissue. That is very interesting, because we heard that the doloclast, the shockwave therapy, can heal muscle cells better and modulate them better, so that they work harder, I would say, and get a better healing. And if you can stop the inflammation and the scar building with the laser, and you put the shockwave on it, you get everything you need: more, less inflammation, less scar tissue, and more work on the muscle cells, and better healing with the fibers. Next one. Now this is a comparison of the shockwave again to, you all know, as I said before, Dr. Müller-Wohlfahrt, and he is known for his injection therapy. He always does that with Actovegin, which is a filtered calf blood there are a lot of amino acids in it, and that's why he told us for the last 35 years that it works in the muscle, that the amino acids work in the muscle and makes it heal faster. Mr. Matiasowski and Professor Schmitz found out that if you use actovegin, only single actovegin, it doesn't have any influence on the muscle. If you use Traumale, which is a homeopathic ingredient, with it, only single, then you have no effect on the muscle. But if you compare both in an injection, you have a positive influence on the muscle, and the muscle heals better and with less scar tissue. But if you only use shockwave, you have better results than with the therapy form of Professor Müller-Wohlfahrt, because the radial shockwave works even much more on the muscle cells than these injections do. And you have no new trauma with every injection you have, because the shockwave is non-invasive, as we said before. Next one. There you can see in the next file. Yeah, that proves that the combination of actovegin and Traumale works on positive on muscle regeneration. But the next one shows with the pictures. Can you put on the arrows? Now you have to believe me, because this is hard to see in this. The effect on the muscle is on the left side with actovegin and Traumale can be seen as a good effect, but on the right side with only radial shockwave, it's a nearly perfect effect. If you compare it with the laser, we are going to do a study in the future. I think the results will be even a little bit better than, or much better than with the radial shockwave on its own. Next one. And we have one study coming up. I think the results will be there next year with our good friend Javier Krupnik in Argentina. He's a professor for physiotherapy in Argentina, very well known, and he works every day with professional sportsmen. And we did a study on hamstring ruptures from type 3B. As I said, we'll have the results that we worked on it with shockwave against physiotherapy, and we will have the results in, I think, at the beginning of next year. And then you can see how it works on the muscle. Next one. These are the 5 typical indications that you all know, and these are the indications that we worked on with the focused shockwave at the beginning when we didn't have the radial shockwave. Now you can treat them with both. But as I said, these are the typical ones, the classic ones, I call them, is the calcified shoulder, tendinopathies in the shoulder, tendinopathies of the Achilles tendon, then the enthesiopathy at the elbow. It's called tennis elbow or golf elbow. On the other side, radius side is tennis elbow, and the other one is golf elbow, ulnar. Then you have the patella tendon with his tendinopathies and enthesiopathies, and the heel spur or plantar fasciopathy. These are the indications that everybody knows around the world, I think. But now we show you some more indications that you might not know. The approved indications that are, as I said, approved, and AMS can tell the clients that they can use them for that, is trigger points. We'll talk about that later. It's very, very interesting. Then the lower back pain, very important, because, for example, in my business, we work with about 40%. 40% of our patients come because of back pain, and we work with shockwave therapy very, very successfully. Then the trochanter pain syndrome, very, very important. A lot of people suffer from this. The mid portion His tendinopathy, I said before, the medial tibial stress syndrome, for example. And that's very important too. Wound management is, for example, also for diabetes feet. Next one. And this is just to show what we work on every day, partially, of course, off-label, but these are additional indications that everybody of you can try on. You have to talk to your patient if it's off-label, of course, and explain why it should work, and they have to sign it, of course, but you can really work on every kind of muscle injury, from the hardening to the muscle rupture. Complete ruptures, of course, should be operated, but if you have older patients that don't want to be operated, they love the shockwave because you cannot heal the whole muscle if it's completely ruptured, but you get the pain away and you get a better healing than without doing anything. And the osteoarthritis in the knee and the fingers, for example, I will show you in the next webinars how we work on the chronic polyarthritis. Then every kind of spine syndrome, sacroiliitis, fractures, pseudarthrosis, bone bruises. Very often we have to work on bone bruises because I think there's no other therapy form that makes it better in that short time. Osteochondrosis dissecans, we had a lot of patients suffering from this over years, and now they're pain-free. Tension headache and migraine. Very often the migraine comes from tension headache, but you can work on all of them if you treat the neck up to the occiput bone. Then the lymphedema, very, very important. I will show you some impressive cases in the next webinars. The Tractor syndrome, the Schlatter disease and Saber disease. Schlatter is, you all know that from the growing children when they get the tendinopathy at their knee, and the Saber or Saber disease is at the same at the calcaneus. And the new one that I was forced to use, can you go one further, is the lung of post-COVID or COVID patients. The next one, please. I had to use the shockwave for my own daughter because she suffered from COVID-19 as myself too, but she had it on the lung extremely. She couldn't breathe for 9 days. She couldn't get up because of the shortness of breath. And that's why I started with a new dollar class device that is portable, as I said. I started treat her after day 9 of her infection, and after 5 days daily treatment, she was completely out of without any problem. Had about, I would say, 5 to 10% lung capacity, missing lung capacity, but she was. She had no more problem to get up and do all the things that she does normally. And today she has no problem. But I don't want to know what would have happened if I didn't treat her with this, because the first 9 days were terrible, and we were thinking about bringing her to the emergency because I had no answer what we can do after using all the medicine that was said that could help. Nothing helped, but only the shockwave therapy. Next one. And we even use that now for chronic bronchitis, and the results are the same as all the long COVID patients we treated. They get better. We tried about, I would say, 12 to 13 patients now, and we have a result of 100% getting better. Not perfect, but better. This is to show you how important shockwave therapy can be. For example, here with professional football players from the first league in Germany, this is how many days they missed in the year 2017 and 18 because of injuries. If you see this once, it makes, can you do the next one? Makes nearly 79% of all injury days in the first league in Germany. And all these indications you can treat perfectly by shockwaves. And that's why I think from the 18 clubs in the first league, now 12 or 13 clubs work with a shockwave. Maybe 14. Next one, and the next one. Because, yeah, and then the next file. So now, why do we use the laser and shockwave together? This is to show you, and this is also to show to your patient what we want to reach. We want to have the effect of less pain and less inflammation when we start with shockwave. The next one, please. I can show you on the next table. This is perfect to show. We used it for different indications, of course, and we had pressure that we could bring to the patient before the laser. Then we did the laser program of 5 or 3 minutes. This is a laser program that is especially programmed for the use with shockwave and with the Doroclast. It's the highest. There's the question if you get the presentation. I see. Yes, everybody can have this presentation if he wants, of course. If you start with 5 or 3 minutes laser and then you give the patient 5 minutes break or better 1 hour break, you can reach much higher pressure with shockwave, and that's why you have much more energy in the tissue and much better results than you had before, because the efficiency, the effect is I think stronger, and it holds on much longer. Very important, very impressive is, for example, this osteoarthritis in the ankle joint. This is mine, the first one. We started with 2.3 bars. It's the highest level that I have a very bad arthritis in my ankle after injuries from football. I can stand 2.3 bar, hardly, but I can. And after the laser, I had 2.8 after 5 minutes and 4.0 bar after 1 hour. That was so impressive to me that I couldn't believe it. I tried it 3 or 4 times and it always worked. That's really cool for myself. The hand polyarthritis, you will see in the next file again, from 0.8 bar. This is with the new device. We start with 1.0 bar, but you have an energetic program, and then you start with 0.8. After the laser, we could bring 1.6 bar on the hands, which is really much. And so we can go on the epicondylitis with 1.6 bar and then 2.8 bar after 1 hour after laser. That's really impressive. Next one. Trigger points. For me, trigger points are very important if I talk about shockwave therapy, because you can do so much good for the patient. This is Professor Matiasowski. He is a spinal surgeon. Nobody would expect if you saw this picture, and we asked him if he can show that to all. Because we were on a congress together, and when we were flying back at the airport, he was sitting like this, and I think this is a perfect example how most of the people in our, as I know, sit when nobody looks at them. And everybody has his iPhone or any mobile in his hand and sits like this. This is a catastrophe for your body, and that's why we always get burning trigger points and painful trigger points, and everybody talks about his back pain and so on. And that's why I want to show you why we can, the next one please, why we can treat trigger points perfectly by shockwave. As we all know, musculoskeletal dysfunction comes from too much load, means muscle overload, or if we sit like this, as you saw in the picture before, in the photo before. Next one. And Mr. Terwell and Mr. Simmons were working on trigger points many years, and they showed us how it works and why trigger points are a real problem for physiotherapists. Trigger points are can be center trigger points and trigger points at the beginning of taut band, which makes them not very easy to treat because only relaxing them is not enough. As you can see on the right side, these increasing fiber tensions work, bring it together to a taut band, which is a local hypoxia. As a result, then the tissue gets stress, and we get the pain that we all know, and it goes on like automatic and autonomic modulation and brings on more fiber tension, brings on harder taut bands, more local hypoxia, and that works on and on and on. And this local ischemia is one of the biggest problems because the metabolism gets better, gets worse and worse. Next one. Now you can see that if you look at the tendinopathy that I told before and the biochemical milieu of the neurogenic inflammation that I explained, we have the same problem if you look into trigger points. You also have inflammatory mediators, neuropeptides, cytokines, and so on in the tissue or in the muscle if you have the trigger points. And so I think it's very clear for everybody that we can work on trigger points perfectly because we can work on tendinopathies perfectly. Next one. And we can cause an anti-inflammatory effect in the trigger point, and we have the relaxing effect of the shock wave to a trigger point. And I'm quite sure that all physiotherapists that try shock wave for trigger point treatment, you can use it nearly as acupuncture in the same points. So we combine Chinese medicine with the typical trigger points with the shockwave therapy. It works perfect. You can even combine acupuncture with shockwave for this. And then you get the relaxing effect, you get the anti-inflammatory effect, and all the physiotherapists will be, I think, will cheer up if you try it and you have the feeling, okay, I don't have to use only my hands and work with my hands on the trigger points, but you can work in seconds on the trigger point with a shockwave and get even better results than with your fingers for minutes and minutes with acupressure, for example. Next one. And next one, this we saw before, it's why we combine it. And now some single points that are very important for shockwave therapy and why it works so great. A tendon needs a lubricant for gliding. Every tendon has this skin, or tendon skin, or the skin around the tendon, I would say. I don't know the perfect technical expression now, but what we need between them is lubricin. Lubricin is built by the body itself when you move. The moving of the tendon leads to to an expression of lubricin, and that's very, very important because if you don't have lubricin, it gets like I would say it gets dry. That's what we see, for example, if people are operated at the tendons and then put into a plaster for weeks, they come out and they cannot move at all. And it's like a glue in there because it's so dry. And that's why we work, for example, with freshly operated patients. After 2 or 3 days, we start shockwave because we want lubricin to be expressed, and that's what is the very impressive thing about shockwave. Shockwave and moving are the two things that bring lubricin up and stimulate the building of lubricin in the tendon. We'll see that in the next one. Here it is said there's a study about that. Shockwave increases the lubricin expression. And it's funny because this is a work from 2011 and it still says low dose and high dose means radial and focused shockwave. As you know, these expressions are completely nonsense. Next one. This is a study just to show you that the wound healing effect of shockwave is proven by a study. If you cannot work on the wound at the beginning because it's, for example, the inflammation in the wound is too big or is bacteria in there, then work on the skin around it. You get a better blood flow, much better blood flow, and you get growth factors in it, and then it starts healing the wound from the side. Yes, there are now some files about the bone healing effect and some information because some people say with the shockwave you can break the bone, the hard part of the bone, which is which is also complete nonsense. You can crack a bone with, or beginning to crack a bone, the cortical bone, with energy of 1.2 millijoule per square millimeter. 1.2, as I said before, the highest that you can reach is 0.55 with the Power Plus handpiece and the dollar class. So you have 200%. You need 200% more energy to get the first little cracks in the cortical bone. That's very important. So if somebody comes and says, "Oh, you break the bone with shockwave," tell him that he's saying nonsense. Next one. This is to show that also low energy is also, again, low energy means radial shockwave can be used for healing the bone. And they say that fractures, even when they begin from osteoporosis, can also be treated with shockwave, because you cannot crack the bone. You cannot crack osteoporosis bone, you cannot crack normal bone. You can help people with osteoporosis because we know that the osteoblasts are working better and better if you put your device, your shockwave device, on it more and more times, and so you can work on a bone fracture that is caused by osteoporosis as well as every normal fracture. That's the same effect on the proliferation and differentiation of osteoblasts. Just a study to show that this is proven. Here are some. It's also a summary for the bone effect. Just to have you known that this is for non-unions, for example. We have a lot of studies that demonstrate that it works. Then the point 4 is accordingly both the Swiss dollar class and the Swiss piezo class can be applied in the treatment of non-unions. Means you can do radial and you can do focused shockwave, as I said before. Now we can go further. The next one. This is important. Number 8 says it has been hypothesized that treating bones with shockwaves leads to increased microcracks, followed by intensified remodeling. That means that the microcracks in the softer part of the bone that we see in every fracture, of course, or even when we have bone bruises, the microcracks can be not increased in the number, but can be hold on longer by a shockwave, and that means that the body brings in more osteoblasts and more growth factors for the bone, and that's why the remodeling goes on and on and on and stronger, and that's why it works how it works. And the number 9 shows, and I put it in red down there, that even with not as high density flux that they said before, with 0.5 or 0.4, but with an energy flux density from 0.15 millijoule, you get the same result on the bone, that it works on non-unions and cracked bone. treatment of the tendinopathies. That's what I want to show everybody, because in Germany we have two systems. I don't know how it is in your country. We have two systems: a private injury system and a common injury system. The common injury system never talked about shockwave and didn't pay for anything over the last decades. Now, for the last 1.5 years, we have a new indication that can be treated by shockwave for the common injuries too. Means the plantar fasciopathy can be treated with shockwaves, but you first have to do all that you can see down there on the left side and in the middle for 6 weeks or 6 months. If you do all these things and it doesn't work, then you are allowed to do 3 shockwave therapy sessions, only 3, and we get about, I think, 26 euro for 1 session. But you have to have your patient waiting 6 months and doing all the things that you see here on the list. For example, corticosteroid injections, even the first 6 weeks, and going on with corticosteroid injections. You have to do x-rays and so on. Therapy x-rays after 6 months, then you can start with your shockwave device, and then you have the possibility to do 3 sessions, and then it has to be gone. What I want to show you is that, for example, in Germany, the common insurances have no idea of modern kind of therapy, and you have to really fight for your shockwave session in Germany if you want to have the patient treated by shockwave. It is not possible to get the money from the common insurance. They have to pay it themselves, or if they are have private insurance, then you have good chances. It is a shame, really a shame, because all these studies that I showed you today are not from the last 2 years. They are older, very older, and we know the effect, the perfect effect of shockwave therapy for years and decades. But it did not come to the mind of the common insurance, for example, in Germany. Next one. This is what I spoke at the beginning. This is the study of Mr. Rompe with the negative outcome. Very funny, because this is the program, the stretching program that Mr. Rompe did to all the patients that did not get the shockwave treatment. And if you read this, I think you have to smile, because this needs 15 minutes, nearly more than 15 minutes. And it should be done 3 times a day for over 8 weeks. And this this stretching torture, I would say, for the patient over 8 weeks is then combined with 3 sessions of shockwave in 3 weeks. And then they compare it after 8 weeks and after 12 weeks, I think, and there's a slightly more positive effect of the stretching exercises after 8 weeks compared to the 3 treatments with shockwaves. The funny thing is that after about, I think, 6 or 9 months, when they did the next evaluation, the effect of the shockwave treatment, only 3, I tell you again, only 3 treatments, is better than after this time when they did the stretching program for 8 weeks. So in my opinion, it was a really good success for the shockwave treatment. But if you see that it has a negative outcome, you now know that it's only for the first 8 weeks, and afterwards it should have had a positive outcome. And that shockwave works longer than all your stretching exercises that you can do. Now, one important, because I spoke against every cortisone injection, and now I will show you why. If you put local cortisone injections in comparison to shockwave, show me the next, please, at the tennis elbow, then you see the gray line is shockwave, the blue one is steroid injection. That after 1 injection, 1 treatment, of course, cortisone works faster for the pain relief, and after 2 weeks, still cortisone leading a little bit, but after 4 weeks, and I think in the 4 weeks they had 3 treatments, you can see that it changes, and that the the pain level goes on to go down with shockwave therapy and goes up again with steroid injections. And if you see that after 12 months, I don't have that, I'm sorry, but if you see that after 12 months, then it is that the steroid injection group comes back to the same pain level as when they started, and the shockwave group goes down to, I think, between 0 and 2. The next one is another pain score, but it's exactly the same as you can see. So if you work with shockwave, you work much better, you work with the chance of healing, and you work without any destroying of the tissue as you do with steroid injections, and you have a much more lasting effect. But that's clear because you get healing. So now we have to talk about contraindications. Of course, all these contraindications are contraindications, and EMS has to tell your patient that this is the case. But I think we have to have a more detailed look on every contraindication. For example, treatment over air-filled tissue. I told you that I treated my 14-year-old daughter with shockwave, especially over the lungs, it means between the ribs, for the treatment of the muscle between it and the treatment of the back muscles, of course, but also for treatment of the diaphragm. That is very important because I can use it there to treat all this without touching the lung. If you work, but it's only for radial, of course. If you work with a focus device, then you can come into 5 centimeters with a very focused, intensive energy level, and that may be that you can have an effect on the lung, and that people could get harmed. I've never heard of that in the whole world, but there is the possibility, I think. But if you work radial, you get into a deep of 4.5 to 5 centimeters, but at the end of this length, there's not the same energy than at the beginning, and you have muscle between it, and you have only a little influence on the lung tissue. And what is very important, people who are really or the lung tissue is really touched, they cough. And if they cough, you have to go a little bit more on the left or on the right, and then it goes away. And this is very easy. And so you cannot, in my opinion, you cannot do any harm to the lung, but you have to tell the people, and you have to get it signed. It's the same with the intestines. There's the risk that there's air in the intestines, so you have to hold your shockwave away from your intestines. Treatment of torn tendons that are more than 50% injured, it's the same. I would tell everybody with an injury of more than 50% of his tendon to go and have it operated, but we have a lot of patients that don't want to be operated at all, and then they ask for shockwave, and then we treat them if they sign that before and say that this is okay. Then we start with this. I think we have very good results because the people lose their pain, and the healing process brings it up to 50, 60, or 70% of the normal width of a tendon. You cannot heal it completely, but we have very good results in the pain. If you look at the pain, and the patients are very thankful if you try that, because if they have an age of 60 or 70, they want to be operated with this normally. Treatment of pregnant women. This is very important. Never treat a pregnant woman, or even talk about it in the reach of the fetus, because I think it should be clear that shock waves shouldn't have the chance to touch the uterus or even the fetus. So don't treat them at the back. Don't even think about it, for example. But if you have the case that, and I had it 2 days ago, a pregnant woman is coming with a carpal tunnel syndrome on both sides and fasciopathy on both sides. She couldn't walk, she couldn't grab. It was terrible for her. Then I informed her that, in my opinion, it is possible that we work on your hand right and left and on your foot right and left without having the chance of shock waves coming in the near of the uterus or the fetus. And I think we treat a lot of pregnant women with this. The effect comes immediately. After the first treatment is better, after the second and third it's better and better, and after 4 and 5 treatments the problems are normally gone. If they come back during the pregnancy, you can do it again, and with no harm at all. Because we are not in the near of the stomach, means the uterus. Treatment of persons under 18 years, of course, you know it from the Schlatter disease. As I told you before, we had a lot of other children that we treated on their muscles, and for example, the Sever disease, as I said before, the calcaneus. You have to talk to the patients, you have to explain it exactly to the patients, you have always to work with no pain with children, because they can't understand why you hurt them. So please, no pain. It works 100% good if you do it without any pain. And you have to keep away from the part of the bones where it grows, from the growth line of everybody. That's very important. And there is a study on mice that is not out yet, but it is was made on mice, and especially treating only the joints and the bones at the part where they grow, with I think pressure 5 times higher than is possible with our devices, and there was no effect on the growing bone, or no side effect on the growing bone, no negative effect. So I think you cannot do any harm, but you have to tell the parents, and you try to keep away from the parts that are growing in the bone. The treatment of patients with blood coagulation disorders, don't work on local thrombosis, especially when they are younger than 1 year, because you never know what you do in the tissue when if the thrombosis can go out and do any harm to the patient. After years and years, I have one patient had his thrombosis 18 years ago, and they are completely checked before. Then we try to do good work on his lymphedema in this extremity, and it works very good. But this is not normal. Don't work on thrombosis normally. The treatment of patients with oral anticoagulants, it's the same. Talk to the patient if he's suffering from things that can be only treated by shockwave. Then talk to the patient and try it in another area. If he doesn't get any hematoma, I think you can try it. I didn't have. I had over the years a lot of people taking anticoagulants, and we had no bigger hematoma over the years at all. But as I said before, you can try it if the patient wants it. If the patient is a little bit anxious, don't try it. The treatment of local tumors or local bacteria. All that I can say is, of course, you are not allowed to go on tumors because you don't want to treat the tumor. That's it's nonsense to treat a tumor with shockwave. No, I wouldn't try. But the same is with local bacterial infections. Not on the local infection if it is at a high inflammation level, but as you will see in the cases that you have in the next webinars, You have special situations where you can try it, and the results were great. But normally you're not allowed to do that. If you work with lymphedemas where the local tumor is in it, you also have to talk to the patient, because there are people saying that you can activate the tumor. I haven't had that before. We were working on 3 or 4 patients the last years with their tumor in the lymphedema region, and they forced us to treat them because of this terrible lymphedema, and the lymphedema went away very fast over the next month, and the local tumors all were not getting worse. So all I can say is talk to your patient and see how bad his situation is, and then you can try to treat, even if it's a contraindication. And the same with cortisone, it's the same. This is a real contraindication because cortisone works with a bad effect on the tissue. We all know that. And that's why we don't work on people having cortisone in their in the reach of the tendons or muscles in the 6 weeks before, because if you work on that and then you get a rupture or something, or a real injury in the tissue, people would say that was from the shockwave therapy. This is nonsense, of course. We all know that it's from the cortisone, but so that you have no discussion, wait for 6 weeks and then you can start again with your shockwave treatment. Next one, I think. That's it. Yeah, that's just to make up your mind if all the contraindications are real contraindications. Now, I try to end all my webinars with my sports philosophers. They that talked about shockwave. They didn't talk really, but as you can see, this is this was Oliver Kahn, one of the best known goalkeepers in the world from Bayern Munich years ago. He said, Eier, wir brauchen Eier. That's German and means balls. We need balls. Here we have eggs. We need eggs. I think balls. We need balls is better. Should tell you that you have to be brave and take your shockwave device and try all the indications that I told you today. And if they are off-label, tell your patient, explain it to him, and then try if he signs it for you. You will have great results. You will have impressive results, and you can help people that never thought that that somebody or someone can help them anymore. This is Bertie Vogt, also one of the best-known German football players decades ago. He's once said, reality is different from objectivity. That's what I want to tell you. You have patients that were treated over years. Nobody was thinking about doing shockwave, and then you do that, and suddenly the reality changes. But the best one, okay. In Germany, quality comes from Egene, means Qualität kommt von Qual. That means that if you are a hard player, a strong player, and you train a lot, you will get better quality from yourself. That's the same with shockwave. If you work with the patient and he accepts a little bit of pain, he can have great results. But the best one is pain is temporary, glory is forever. This is what brings up shockwave effects the best way, because a little pain at the beginning for your patient, and then glory because of healing. I think this is very obvious for everybody who treats with shockwave. Okay, and then I end with another football player from Germany, Horst Rubesch, if we get the last file. Once he said, I just say one word, thank you very much.
Thank you, Peter. That was a great presentation. We made it. We made it, even if we had this technical issue. Thank you very much. That was an interesting presentation. And if some of you have a couple of questions, please do so, and
okay.
answer them
I see
live.
them. Perfect. Yeah. I see the questions. Shall I go on? Because I think my tone is a little bit better than yours.
Maybe. It's funny because
we have the question of Mr. Sahan, is it safe to use shockwave therapy over the lungs? We are working over the lungs for people having problems with their intercostal muscles and the back muscles with hardenings and something. We're working for years on that, and there's the lung down behind it. And we have absolutely no problem with the lung because, as I said before, when the patient starts to cough a little bit, go away from this region, that's no problem. With a radial, especially with a radial, not with a focused. I never worked with a focused on on the lungs. If you work with the radial, we never had any side effect, any bad side effect on the lungs, and the effects are really, really very good. But you have to tell the patient. That's very, very important because it is officially, it is a contraindication. But if you tell them before and they know it, and you tell them that it's possible that they have to cough and so on, then it's absolutely no problem. And the results are really, really great, even in chronic bronchitis.
Thank you. I just mute myself because I don't know. I hear myself well, but I don't know if you hear me.
No, we hear in a not so good way, but it's okay.
That's okay. Okay.
Yeah.
I had a question myself, so yeah. I don't know. It's a question which came from another webinar concerning the treatment of ganglions. Have you ever?
We did this hundreds of times. It depends. Sometimes you can really work very good on ganglions because then you reach the result that they go away after 3-4 treatments very fast, and the pain is going away after 1 or 2 treatments. But you also have ganglions, in most of the cases, ganglions that they have for a longer time. Then it may be that you do 5, 6, 7 treatments and you cannot reach any, you cannot have any positive result. Then they have to be operated, but you always can try it, always.
Okay, perfect. Thank you.
And you have no bad side effects. No, never.
No side effects.
No.
I think we don't have any additional questions. Any questions?
I think it was too much for everybody. I'm very sorry.
It was a great presentation, though, but everybody stayed during the presentation, so that's a good sign, very good sign.
Very good. But you can really ask, there's no stupid question at all. Ask whatever you want.
What about CTs? This is a question from Youssef.
CTs, what a carpal tunnel, or what did you?
Carpal tunnel syndrome.
Joseph, what do you mean CTs?
I'm writing to him right now.
Carpal tunnel, yeah, perfect. Yes, you can. If the carpal tunnel problem is has been there for months and months, and the neurons are you have the feeling that it gets completely numb or they cannot use their hand anymore. Then it's too late in most of the cases. But if you start to work as early as possible, you have great results with the CTs, really, really great results, because the carpal tunnel syndrome is like a lymphedema in the carpal tunnel, and you can bring it out completely. You have to work on the whole hand. We always work, sorry, there we are. We always work from the beginning of the fingers over the whole hand and then through the carpal tunnel and then up to nearly the elbow to bring all the edema out of the carpal tunnel. And then everybody asks if this is an effect that's only for 1 or 2 days. If you treat them once a week, I would say 3, 4, 5 times, then you see the result that it lasts longer and longer. And after, I would say, 7, 8 treatments, most of them have no problem anymore. And there's even also no problem with the nerve or something. You can, as the pain is okay for the patient, you can go and give him.
Okay, perfect. Thank you, Peter.
A very good question, because this is something that most of the people with shockwave devices could do and don't do because they are frightened of doing any harm. No, you don't do.
Do you get the same results for treating a carpal tunnel syndrome as well as a trigger finger?
As a what a finger? Sorry, didn't get it.
Finger, you know.
This finger.
Yeah. Yeah.
The problem here is that this is a mechanical problem. You get the pain away, and sometimes you get it a little bit smoother. But you normally, if you have reached this clip finger, you cannot get it completely away, but you get it better, of course. And a lot of patients come after we treat it 3 or 4 times, it's better, and then they come only every 6th or 7th or 8th week, and they say, this is okay for me. I don't have to have it operated because the pain is away, and with this little bit of trigger, I can live, and so that's also possible.
Okay, perfect. Thank you. Any additional questions from participants? I think we are done, and we are a bit late, but well, this is.
What we can do, we have other webinars for the practical things and so on, and we have the same participants. You can even think about your questions and then ask me at the beginning of the next one. I think this would be perfect because sometimes you have the questions after an hour or 2 or 3 days, and then let's do it like this. Oh, there's one more question. Yeah, that's no problem. He is asking, I have a patient with delayed union of fracture of scapula, very interesting. What do you suggest? Very interesting case, but no problem. Go for it. And do it with the radio. You can even do it with the focus here because the scapula is thick, about 1 centimeter, and you have to use the very short how do you call that, pillow, the gel pillow on it for about 1 centimeter, but then you can even use the focus on the scapula. That's okay because you have a muscle layer over it. That's perfect. What parameters? Very good. Hey, Yusuf, you're cool. Good questions. For example, at the beginning, I would say 1.5, starting with 1.5 bar, always 20 hertz. That's very good theme that we have to discuss. Also, always work with 20 hertz or 25 with the new dollar class, because as you saw on the file, the energy level doesn't go down with the same way as from the competitors, who go down like this, and the dollar class goes like this, and after 15 hertz it's a little bit down, so that doesn't matter. So work always with 20 hertz. You have no time to lose, and that's why we always work with 20, or with a new device 25 hertz, and then start with 1.5 bar. I think this would be possible for the patient, and ask him about the pain, and then go only go over the whole scapula, because you want to activate the whole bone. Go over the whole scapula, and with the focused one, with an intensity of 1 and 2 at the beginning, and 1 centimeter deep, go into the region where the bone doesn't heal. And then I think you will have great results after 6, 7, or 8 treatments. It's not 2 or 3 treatments. That's nonsense. Some people tell that, especially in the internet videos, it's terrible. You have 3 treatments and every non-union is healed. That's no. You need more. I had patients with 15 treatments.
So the highest is the frequency, the more efficient is the.
Yeah, you only need the highest frequency. There are some people, I would say 1 of 100, who wants it more like 18 hertz. It's a little bit better and not so painful than 20 and 25. But this is only really 1 of 100. All the others, except 20 and 25, very well.
Perfect. Thank you. I think we are coming to the end of our webinar.
Yep.
Thank you very much, Peter. That was a great presentation, as always.
Thank you.
Thank
all the participants.
Yeah, thank you all for participating, and we'll keep you informed about the next session about GDT, a practical session, which is a very good idea. So we'll let you know, stay tuned by email, we'll keep you informed by emailing. Tomorrow we have another session, a practical one class with Daniel Morgan. So for those who would like to register, please do so online. Thank you again, Peter, and we'll see you next time with you, Peter, in October for the double class sessions, practical sessions.
Yep, I'm really looking forward to it. Thank you, Marie-Christine.
Bye-bye, everyone. Bye-bye.
Bye.